Welcome, everyone. We're glad you're here tonight. I'm Ginger from Grow Midwives, and we're excited to bring to you a topic that has been an issue in midwifery and other non-physician provider professions since I practiced over 40 years ago. The concept of a physician billing for our services is one that we tend to dance around quite a bit. And as I noticed in a comment over the past 2 weeks when we were advertising tonight's webinar, a midwife saying, well, the elephant in the room. Well, if we talk about this and, they decide that they could get in trouble for us being there and billing the way that they want to bill, then they'll just get rid of us. And so we want to tackle that fear because knowledge is power, and having facts is helpful so that you're a part of a conversation that you have an awareness of, but you approach it in a non-threatening way, but rather sort of an academic or a fact-based way. So we're really, really honored to have Arden Schwenker with us. Arden will talk a little bit about her background before she dives in and does the majority of this presentation on understanding what Incident 2 means. And I think Arden's going to talk to you about how to take questions. We certainly have enough time at the end as we move through the conversation. So we'll be here for you to answer things. I do want to let you know we are recording the session. We do put it in the public domain, just so you're aware of that. So Arden, you want to take it over?
All right. So first of all, I want to make sure everybody can hear me and can see my screen, because when I started sharing my screen, I lost all of your videos somehow, including my own.
Yeah, we see you fine, Arden.
Okay, perfect. So just a little bit about me. My background is in healthcare billing and compliance with a primary focus on midwifery and birth centers. And in doing some research for the new laws pertaining to midwives, birth centers compliance for 2022, I stumbled upon how the Center for Medicare and Medicaid Services has changed Incident 2 billing guidelines. And that is what prompted tonight's webinar, is to go over the changes with each of you, make sure you understand them or are aware of them, and to start a discussion pertaining to them. Just so you know, there's a lot of information on the following slides. Please don't be afraid to ask questions either as they come up. I don't mind if you ask questions as they come up or at the end. So the first thing that I wanted to go over is what Incident 2 billing is, because that can be confusing to a lot of people. Incident 2 billing is a CMS regulation that allows a physician to hire a non-physician provider to work in their practice as a way of getting 100% reimbursement. And Incident 2 started only through CMS, Center for Medicare Services, as a Medicare guideline for Medicare patients. However, the other federal payers soon adopted it, and now most commercial insurance payers have adopted the Incident 2 guidelines as well. What it means is services are submitted to insurance under the physician's NPI number, but they're performed by a non-physician provider. And Incident 2 must be based on a previously identified problem and a plan of care previously established by the primary physician. So in a nutshell, the primary physician needs to see the patient first. They need to diagnose the problem, and they need to establish a plan of care. So how does incident 2 work? As I said, the physician must see the patient on the first visit, establish the diagnosis, and initiate the plan of care. The non-physician provider, the NPP, may then provide follow-up care under the direct supervision of a qualified physician. Direct supervision means the physician must be physically present in the clinic and immediately available. It doesn't mean they have to be standing in the same exam room. It's fine if they're in the office building, but it also doesn't mean they can be down the street grabbing a sandwich while you're seeing the patient. They have to be in the clinic. Services must be the kinds of services that are commonly provided in a physician's office. And as an additional caveat to incident 2 billing, most state Medicaid plans do not allow incident 2 billing. So it's really important that you know your contracts, because most state Medicaid plans state that the provider that renders the care has to be the provider that bills the care. And incident 2 billing applies only in an office setting or for some home visits. And we'll go over those guidelines as well. So who can provide services incident to a physician? CMS defines non-physician practitioners as physician assistants, nurse practitioners, and certified nurse midwives. They also state that auxiliary personnel can provide some services incident to a physician, such as RNs, technicians, and other qualified personnel employed by the physician or by the legal entity that employs the physician. NPPs must be credentialed with the payer and able to submit claims under their own NPI. Payment is then made under the NPP's physician rate of 85%. Or they can provide services incident to, and then payments made at 100% of the physician fee schedule. The most important difference here is if they're incident to, it's 100%. If they are providing the service themselves, providing the service yourself, it's 85%. Certified nurse midwives are paid at 100% of the physician fee schedule, according to CMS. However, not all payer contracts are set up that way. And then the other big important piece to remember here is that in order to bill incident 2, you have to be credentialed with the payer and you have to be able to submit claims on your own. If you're not credentialed with the payer, you cannot bill incident to the physician. So how this applies to CNMs. Again, Medicare states that a CNM is reimbursed at 100% of the physician fee schedule. However, many of the commercial payer contracts still list CNM reimbursements at 85%. If you are under a contract that still reimburses a CNM at 85%, it's always a good time to renegotiate those contracts. If a physician initiates care and establishes a diagnosis, all subsequent visits performed by the CNM are considered incident to the supervising physician and must be billed under the physician's NPI. If the CNM initiates care and establishes the diagnosis, then all subsequent visits are performed by the same CNM are billed under their NPI. And CNMs are not allowed to supervise other provider types, meaning a CNM cannot supervise a CPM or an LM, a certified professional midwife or a licensed midwife cannot bill incident to a CNM services. Now, how it works with global maternity care. The total OB package or global maternity care includes the provision of antepartum care, delivery, and postpartum, as most of you are aware. When the same group physician and or NPP provides all components of the OB package, report the global maternity code I noticed a typo, it threw me off. When the same group physician or NPP provides all components of the global OB package, you report global maternity care under the provider that delivered the baby or under the physician that initiated the care and oversaw the treatment during the entire global period.
So Arden, this might be a good place to pause.
I think so too.
Some of the discussion that we're hearing in a variety of venues is this scenario where the midwife does not have admitting privileges, hospital privileges. The midwife is delivering the baby. The physician is not present, and the physician is billing for those services.
Mm-hmm.
So is it possible that the physician who initiated the care and oversaw the treatment can do that?
So that's where it gets tricky. First of all, if the CNM does not have admitting privileges, then they are not a billable provider under payer contracts. In order to be billable, you have to have admitting privileges or you can't bill global maternity care in the hospital. So
and say that again, is that with commercial or does that include?
That includes Medicare.
Medicaid.
And Medicaid. You have to have admitting privileges in the hospital to be on the hospital contract or to be on even if you're not a hospitalist, if you have your own practice and you're delivering in a hospital, you have to have admitting privileges to bill for any care in the hospital.
So I have a question. So privileging can be different. You can have hospital privileges and be able to do everything a CNM can do legally in a hospital, but the hospital requires that the patient is admitted under the CNM's physician. So does that, you have privileges at the hospital, but you're technically not allowed to admit under your name. You admit under your doctor's name. And I know most HCA hospitals do it that way, and that's the biggest corporation in the country.
Which I believe that is fine. You're still admitting, you still have privileges at the hospital.
Yeah, privileges, not.
And you can still bill the care because you have privileges at the hospital.
Okay. Just want to
But the scenario that we've heard recently is the midwife that's delivering the baby is not on the contracts. They don't have admitting privilege. They don't have any privileges at the hospital. They are there as an ancillary provider delivering the baby. The physician is not in the room or even the building, and attending is standing in the corner watching to make sure that the baby is delivered successfully.
Okay.
And that is not incident to billing.
Right. Gotcha.
What are other people thinking as you hear this potential landmine?
I'm thinking that it's going to completely make data collection impossible. How do you track what a midwife does and what value they bring if they're not the ones that are generating the income, because the physician is the name on all of the charts?
That is a very good point that we have argued. And they say, oh, but the EMR will do that for you.
Yeah. No, it doesn't.
It doesn't.
And I guess another big question is, why are the midwives billing incident to the physician when the new CMS regulations state that they should be paid at 100% of the physician fee schedule? Well, I know the answer to that. It's because nobody in the hospital system wants to renegotiate their payer contracts because it's very labor intensive to get the CNMs paid at 100% of the physician fee schedule.
Well, and I
with the
think
commercial payers.
there's a lot of non-understanding, I guess is a kinder word than ignorance, that they don't know that midwives are reimbursed at 100% because they're used to the nurse practitioners who are at 85%. And
Correct.
so, we're always lumped in with the nurse practitioners when, as we know, CNMs are very different. I don't know why hospital corporations can seem to understand that CRNAs are very different from nurse practitioners. They seem to have gotten that message pretty clearly. But the midwives, I guess it's just not enough of us. I don't understand why it's so difficult to wrap their brain around, but it's very hard to get administration to understand how different a midwife is from a nurse practitioner.
Well, and the other side of this is incident to billing only applies when you're billing place of service 11, which is an office, or place of service 12, which is the home. It doesn't even apply in a hospital setting.
So it should just never be done in a hospital, period.
Correct.
Well, that's
I was waiting for
Wait.
somebody to get around to that point.
So are they billing under the physician's name also?
Yes.
Yes.
In most hospital systems that I'm aware of, they are billing under, the midwife is delivering the baby and the claims are being billed under the physician that admitted the patient.
whether
So-
the physician ever saw them or not.
Correct.
They're at home asleep.
Right.
I guess I'm just curious what the right way to bill that would be. If the midwife has no admitting privileges and the doctor's not present, how should it have been billed?
It should be billed under, the correct way to bill it is under the midwife. If the midwife has privileges at the hospital, whether it's admitting or not, then it should be billed under the midwife, even if the doctor admitted.
If you start back with the foundational argument here, if a midwife is providing care and has no privileges that have been signed off, she shouldn't be doing anything there anyway.
Correct.
If I were reviewing that in a court case, I would just say this midwife was an idiot. I'm sorry, guys. You cannot do things in a hospital without being privileged to do them. So admitting people is a very debatable and heated topic right now that ACNM has taken on, that midwives should have admitting privileges. This conversation is talking about whether you do or don't have admitting privileges. You simply can't just go in and make rounds on a postpartum patient and touch the patient and write orders if you don't have privileges. And any hospital that's allowing that to happen under the direct supervisory role of a physician who says, go do that, those midwives are in deep trouble.
And so is the physician. Because the other thing, especially when it comes to billing claims, the provider whose NPI number is on the claim is responsible for the entire claim. If the claim is billed fraudulently, the provider is responsible for that, not the hospital, not the biller, but the person who rendered the care.
It might be the midwife, as you're going to find out in some redacted
Or-
contracts here in a minute.
It could be the midwife, exactly. Well, according to CMS, it's in the Office of the Inspector General, it's the provider who submitted the billing. Now, what you will find out, as Ginger said, as we go through the webinar tonight, you will see that there are contracts out there that try to put that responsibility back on the midwife.
And my guess would be that these practices who are doing that and the physicians are doing, the physician doesn't know that what they're doing is wrong and that they would be held responsible.
I completely agree, because this isn't taught. It's not taught in medical school. It's not taught in midwifery school. It's not taught in nursing school.
Go ahead, Shayna. I see your hand.
I've never had opportunity to ask this question, and I'm not sure if this is 100% like goes with incident 2, but you know how sometimes you're in the hospital when you have your patients there and you're doing deliveries, and there's another patient from a different practice and their provider doesn't make it. And so you step in to catch the baby as a favor because that kid's coming out and somebody needs to be the provider. In that instance, I've had 2 scenarios. One where that provider tells me, you go ahead and bill. Or 2 where they've done the billing and sometimes they've said, I'll have my practice reimburse you. Like they'll do something on the back end where they like send our practice $500. I have no idea how that works. What about those types of scenarios?
So the correct response was the first, where they tell you, you go ahead and submit the bill. You caught the baby, you're not employed by their practice, so therefore you should bill for the delivery. And they can bill global antepartum care and they can bill the postpartum care.
Same thing goes for when you're covering call for a different practice. Whoever, the rule is whoever catches the baby has to be the biller. Now, if you return money to somebody, you know, that's a whole different ball game. But whoever's hands the baby's born into, that's the person that needs to be doing the billing.
Just wonder if that was the scenario, because at my last hospital, it happened all the time that there were 3 or 4 providers that were loan providers that cross-covered each other. And when they said when they would deliver somebody else's practice's baby, that practice would still do the billing and then they would transfer each other money somehow.
I mean, wouldn't that be considered fraud?
Yes.
Okay.
I was just waiting for
Wanted to
somebody
make
else
sure
to
that my
say it.
mind was
instead of me.
thinking
Yeah,
that's
well,
lying.
That could be a Stark violation too, which is something else. But so that's a very sticky thing. But I think what happened is that CMS, there was a lot of gray areas, and that was one of them. That the rules weren't very clear on. Now they're very clear, but not everybody is aware that the rules have changed and have cleared, and now there's less room for interpretation than there used to be.
And they're getting harsher.
Exactly.
By you saying, well, I just didn't know.
And they don't, that argument doesn't matter anymore. I just didn't know. They are imposing monetary fines, they're imposing civil penalties and jail time. And the saddest part in all of it is like the new changes for incident 2 billing were buried in a 4,600 page document. And who other than me thinks to read a 4,600 page document?
Hopefully all the office managers and billing offices
They
and
should.
the chief financial officer of institutions, they really should. I'd be curious here at the end of the webinar, how many of you have heard about the new changes with 22? Because it's not, I don't see it talked a lot about on social media.
It's not, and I was alerted to it because I received an email of somebody inviting me to their webinar for the low price of like $800. And I'm like, well, I can find this myself instead of paying $800, which prompted us to do the free webinar for all of you.
Arden, just to give me a flavor, what kind of fines, civil charges, and jail time are being discussed?
So I don't know if I I don't think I put them in the slides, but the fines can be as small as the payer just takes back the money and slaps you on the wrist and says, okay, don't do that anymore. They can be as severe as $50,000 per occurrence, meaning every claim submitted is a $50,000 penalty. They can be as severe as you are sanctioned by Medicare and you're no longer allowed to bill Medicare or Medicaid. There's a hospital near me, I'm in Iowa, and there's a hospital in Illinois that was sanctioned by Medicare for fraudulent incident to billing, and it shut down the hospital.
We talked to a big health system earlier in the week in the South, who will remain nameless, about adding midwifery service to their institution. And one of the things the department chair said when Arden mentioned the complexity of billing and making sure midwives are being billed for correctly, you know, the history of that hospital was they got into some serious trouble with Medicare and Medicaid, and they don't want to do that again. So they really perked up when they heard Arden talking about some of these issues because they actually didn't know.
All right, are we ready to move on?
I have one last question.
Okay.
So when you said that the provider that delivered the baby or the physician that initiated care, so in a collaborative group practice, as long as the physician did like the new OB visit, then they could technically bill the delivery under that physician. But you said oversaw treatment during the entire global period. What is the requirements to say somebody oversaw treatment?
So let me see if it's on. No. I was going to see if I put that on the next slide. So the requirements to oversee treatment are that the provider who initiated care and initiated the diagnosis, as long as it's a non-complicated pregnancy, normal, nothing changes, there's no problem-focused visits, then they just need to be present in the provider who initiated the care needs to be present in the practice during the prenatal visits, or a member of the physician group needs to be present in the practice during the prenatal visits. So that way, if there's a complication or if the diagnosis changes from normal OB, normal prenatal care, the physician has to come in, sign off on that diagnosis. They also have to countersign or authenticate the charts for the prenatal visits. And I believe that's in one of the slides as well.
You know, Arden, where it may be getting a little confusing. This is why this is just like way above my head. If the incident to billing does not pertain to inpatient billing, right? It's ambulatory and home care.
Correct.
But the global fee includes the birth. I see Sheena shaking her head over there. I think that's where she was going. Are they getting away with being able to bill incident to for the birth because it's a global fee, even if the OB is not there?
So global maternity care has its own little carve out caveat. So when a CNM is providing care, and that's where this slide comes in, when a CNM is providing care that's part of the global period, and a physician who is not part of the same group provides a portion of the care, like, for example, you deliver someone else's, another practice's baby, that's not incident to billing. That's split billing. As a CNM, you bill your portion, you bill the delivery, that other practice bills their portion. If you are part of the same practice and it's a collaborative practice, then during the global maternity period, you can bill, or the physician can bill the delivery even if you have caught the baby. The big thing is you have to have privileges at the hospital to catch the baby. Because in order to bill incident to, you have to be a billable provider for that service. You have to be able to bill it on your own, or it's not true incident to billing. And Ginger, I was just thinking as we go through this, I can write something up specific to global maternity care that we could put with this on the website.
Yeah, I think that's a good idea because this is an area where it gets a little confusing. And in a minute, Arden's going to talk about split and shared billing, which is completely different than incident to billing. And then, we're going to throw the word global billing in. And so it all just becomes this hodgepodge of absurdities to be able to decipher at what point in time do each of these unique billing methods apply. And I think the area of greatest concern that I've heard from is midwife, physician work in the same practice. Midwife does 75% of the births. Physician not in hospital. Physician bills for all of the births that are attended by anybody in that practice.
And that's complex for more than one reason. One, physician wasn't in the hospital when it was billed incident to. Two, physicians billing for 75% of the births that they didn't attend. So how are the RVUs split?
Don't even go there, because then we're really going to get into another Pandora's box. But
a lot of those things are on salary, are not necessarily involved with RVUs.
True. Okay, so up next, what does direct supervision mean? So direct supervision in the office, the physician has to be present in the office suite and immediately available to provide assistance and direction the entire time that the NPP is providing service. Qualifying incident to services must be provided by an NPP qualified to provide the service under the scope of your license. So if it doesn't fall under your scope, it's not incident to. The physician must directly supervise, and the NPP, or in most of these cases, or your cases, the CNM, must be a W-2 employee, a leased employee, or an independent contractor. And in a group practice, any physician member of the group may be present in the office to supervise the care. So physician A might have seen the patient for the initial visit, established the plan of care, but they're not in the office for the next appointment, but physician B is there, and that's acceptable under direct supervision. Direct supervision in the home means the physician must be present in the patient's home for the service to qualify. The exception to this is if the patient is homebound in a medically underserved area where there aren't any available home health services. And there is a very specific list of services that it applies to in the CMS manual. And it's quite extensive, would have taken up a lot of slides. The physician must order the services, maintain contact with the MPP while they are performing the service, and retain professional responsibility for the service. CMS recommends that the physician is on the phone while you're providing the service in the home. Services provided in the hospital or birth center do not qualify for incident to billing. And in the birth center means the actual patient has been admitted to the birth center, not the office or clinical portion of the care. Billing guidelines for incident to. So first of all, as we discussed earlier, the NPP personally provides services to the patient. They independently chart the service, then they can bill under their own NPI. You have to be able to direct bill under your own NPI and license in order to bill incident to a physician. And then incident to billing is services that are furnished by the NPP incident to a physician's professional service. And they're billed under the physician's NPI and reimbursed at 100% of the physician fee schedule. And I'll go back to the whole basis for incident to billing started when only MDs were reimbursed at 100%. So in order for them to get full reimbursement and provide more care and have a physician's assistant, a nurse practitioner, and CNMs in the practice, CMS came up with incident to billing guidelines. So here's the little chart that breaks it down a little more. So the situation is it's an established patient. There's no new problems. The physician has already seen them. They've already established the plan of care, the diagnosis. So then you as a CNM, you see them. The billing is incident to the physician. Or if they're an established patient with a new problem and they've only seen a CNM or a nurse practitioner, then they need to be billed under the CNM or the nurse practitioner. If they are an established patient with a new problem and the physician sees them first and then passes them off to the nurse practitioner, the PA, or the CNM, then it can be billed incident to.
I think what's
Questions?
important to remember here, and Arden, you might want to kind of restate this again. All commercial payers do not reimburse at 100%. And
No.
that's the problem,
Correct.
right? Especially if you have a very large commercial population. The
Mhm.
docs want your care billed at 100%, not
And most
85,
Medicaid
75.
plans, exactly. And most Medicaid plans don't reimburse at 100% either. They reimburse at 85%.
Right.
And the
How do we
commercial
get that to
plans
change?
are, I'm sorry, what?
Is there any way to get that to change?
Mhm. You just have to renegotiate the contract, and
Mhm.
I think nurse midwives are in a good position to insist on that 100% because we're getting more interest from payers wanting to have more midwives in their networks. So
Correct.
it's a good time to insist on that. But if you're an employee of a practice, you don't have any control over that. You have to go to the practice manager and say, hey, when this comes back for renewal, take out the 85% for me because CMS says I can be paid at 100%. So you need to negotiate that 100% so we don't get in trouble with insurance fraud.
And that's a very good point. And the thing that the practice managers or the credentialing department of a hospital system need to keep in mind is, yes, first of all, CMS says you're reimbursed at 100%, So the commercial payers should follow suit, but also the federal payers should follow. The federal payers are supposed to follow the same guidelines as CMS. And the federal payers are Federal Blue Cross. Aetna now is a federal insurance company. They have federal plans. TRICARE still has a physician fee schedule and a non-physician fee schedule. And they should be following the CMS guidelines as well.
I bet they don't come to you and say, would you like to modify your fee schedule?
They never do. You have to approach them. So earlier we touched briefly on the documentation requirements for incident 2. So when you are billing and you're billing incident 2 of physician, you should reference the supervising physician. You need to reference they were present in the office or that direct supervision was provided by a physician employed by the same group. And CMS, their rules state that you should have a statement such as, I'm providing follow-up care for this patient under the direct supervision of Dr. Jones, who was present in the office suite. And then the physician is supposed to review the chart and sign off on the visit. If that documentation doesn't happen, then the claim should be billed, the visit should be billed under you and not the physician. Now, because nobody is confused by this at all, we're going to go into, and that's me being facetious, we will go into split or shared billing and how that's different than incident 2. So effective January 1st of this year, a split shared visit is a medically necessary E&M visit in the facility setting that's performed in part by both a physician and an NPP who are in the same group. So I would venture to guess that most of your visits are actually split or shared visits and not incident 2. In split billing in the facility setting, one practitioner, not necessarily the one that bills for the service, must see the patient face to face. And then the practitioner who provides the substantive portion of the services bills with modifier FS under their NPI. So a key component to all of this, a little wrench in the caveat, is whoever performs the MDM, the medical decision-making in its entirety, may bill for the service. Or whoever spends more than half of the total time performing the service may bill for the service. And then Medicare will reimburse at 100% if it's a physician, 85% for a non-physician provider, unless it's a CNM. And then reimbursement varies depending on the payer, the contract, and the state.
So a couple examples I saw in the literature with agencies talking about this are emergency room physicians who hire nurse practitioners and PAs to work in their practice group. And the ER department, kind of like anesthesia, hires CRNAs and anesthesiologists to run the hospital's anesthesia needs. This, what Arden is sharing right now, seems to be the most confusing of the changes that have come out and how this varies from incident 2.
Exactly. And I'll flip to the next slide, because here's a list. There's a specific code set that can be split or shared billed. And you'll notice global maternity care is not on there. Outpatient visits in the facility, hospital admissions, subsequent visits, the discharge visits, the ED visits, prolonged care in the facility, and the critical care services can be split billed or shared billed. And then there's also a list of what cannot be split or shared. Outpatient consultations, inpatient consultations, procedures. They must be fully performed by the billing provider.
My guess is this is all in response to anesthesia, because it is very common that an anesthesiologist would have 8 ORs running with a CRNA and walks in the room for 5 seconds during the induction of the general, and then to the next room, the next room, the next room. And the argument is you can't directly supervise 8 people under anesthesia at the same time. They took advantage of that, and that's probably why these laws got changed.
I would have to agree with you. So moving on, can a midwife employer bill incident 2 for services rendered by other team members? So for example, a CNM owned practice, can you bill incident to the CNM for services performed by a CPM, an LM, or a DEM, depending on the state?
Nope.
In short, the answer is no. Certified nurse midwives and certified midwives are considered a non-physician provider and cannot supervise another team member under the new Incident 2 billing guidelines. Anyone billing incident to another provider must be credentialed with the payer and able to bill for the services under their own NPI. The only exception to this rule that I found in all of the literature was an RN visit for an injection, such as an immunization, or an RN visit for a pregnancy test. Failure to strictly comply with the requirements of Incident 2 billing can subject you to significant liability under the False Claims Act. And one thing that I forgot to add, I thought I added it to this slide, but I forgot. I'm going to go back here for just 1 second. What makes it even more confusing in the new guidelines is it says that a CNM can bill incident to themselves. So I read that several times to try to determine what it meant. And after a lot of digging, what that meant is a CNM can bill incident to for an RN visit, such as an injection, an immunization, or a pregnancy test.
Which is important to know if you want to capture as much billables as you want to capture.
Exactly.
Okay, can we do that in real time? So my midwife owned practice, I have a patient come in for just a just a ROGAM injection. They've already seen for their regular prenatal visit, but they just need their ROGAM. So they come in and I have an RN on my staff and they charge the, what is it? It's like the lowest code. It's like 99211. 212 for an RN visit and the injection. So that would be billed incident to the CNM?
Correct. Because they're just coming in for the ROGAM. You've already established they need the ROGAM. You're not seeing them for a prenatal visit. They're just coming in to get the ROGAM. And it used to be 99211, but that they did away with that code this year. So now it's 212.
And you as the midwife would still need to be in the property, on the facility, even if you don't,
Correct.
you have to be in the building.
Correct. You have to be in the building.
Arden, can you talk about when you have a new hire and you're in the process of getting them credentialed?
Well, that's become a little trickier this year also. So technically, you're not supposed to bill any care. Well, you can't bill any care under their name until they're credentialed. And technically, they should not see patients on their own until they're credentialed, but that's not realistic in the real world. So I am not exactly sure how the laws apply in 2022. I
So-
need to look that up.
If you, let's say you signed off all their charts and they didn't do any of the new OBs, they just did the return prenatals, and could you bill incident to then under your MPI as their supervisor while they're going through orientation?
Well, those visits aren't billed.
Well,
So if they're just seeing return OBs, you bill global maternity care. Those visits aren't billed to anybody.
Well,
So
that's,
yes,
unless
but
straight Medicaid, then you're billing per visit.
correct. If it's straight Medicaid and you're billing per visit, then a credentialed provider with Medicaid has to see the patient.
Okay.
But if it's commercial plan where you're billing, or in a state where you can bill Medicaid globally, then as long as it's not a problem focused prenatal visit, if it's just routine OB, you're not billing it to anybody.
Right.
So the new hire can see the return OBs before they're credentialed.
So they just can't catch any babies
Mm-mm.
until they get their credentials.
Correct.
Okay.
They could be your birth assistant though.
But you're saying they can't also do any new OBs in the office?
Correct. Because they can't establish the care until they're credentialed, because they're technically not a billable provider until they're credentialed. Now, you could do it. I've seen some practices where they do it payer by payer. So when I was working for a billing service and we were doing the credentialing, we would let the practice know. Leslie was just credentialed with Aetna. She can go ahead and render all care to Aetna or Medicaid or whatever the case may be. It's hard for your front desk to track or your scheduler to track, but it's also what you have to do to be compliant.
Arden, I have a question. This is Kate Parks. What about with a student midwives? I mean, obviously you're in the visits with them, but they, do a lot of hands-on, training. Obviously we're in direct supervision.
Correct, but student midwives are different. So the way to think about your student midwife is think about the resident to an MD. So you have to be in the visit. Well, I don't know, MDs aren't always in the visit with the resident, but with a student midwife, you need to be in the visit with them, and then the visit's billed under you. And certain states have different requirements when it comes to Medicaid and the student. And Kate, I know it used to be in Alaska, it used to be that for Medicaid patients, the student can't lay hands on them, which is, I don't make the rules, or I wouldn't agree with that.
Needs to be renegotiated.
It needs to be renegotiated. And it might have changed. I haven't read the rules, the requirements in the past year or so, but up until at least last year, the student technically could not lay the hands on the patient. Now, in a practice that's predominantly Medicaid, it's
Problem.
a problem.
Yeah, how do you get students trained in Alaska? Because my guess is it's a lot of Medicaid in Alaska.
You take it to the legislature, Kate, and you push hard. If any state can do it, Alaska should be able to.
Yeah, well, we've got a whole nother ball of wax with our legislature right now
Yeah.
that's happening, so.
Yeah.
Do we have other questions?
There's
before-
one
Okay.
from Julie that isn't about incident 2, but I think it's worthy of answering. If someone comes to the office for UTI symptoms and also happens to be pregnant, does that get billed within the global package?
Well, it used to be that a UTI could be billed as a problem-focused visit, but some providers overused that, and all of their patients would have at least 3 UTIs per trimester. So now it's included in global with most payers.
Arden, are you saying we can't do, because what we would do is see them for the UTI and have the diagnosis be pregnancy incidental. So we'd bill it as a level visit and then put pregnancy incidental.
I would leave pregnancy incidental off the claim, because if you put the pregnancy diagnosis on the claim, then it's going to, the majority of the time it's going to deny as inclusive to global.
That would be similar to a confirmation of pregnancy visit. You can't put that down as, you don't want to mention the pregnancy until, oh, she happened to come in because she missed her period, and guess what? We figured out why, because she's pregnant. But if you call it a pregnancy visit, then it needs to be part of the global and not separate.
And correct. And with a pregnancy confirmation visit, if you start the prenatal record, it's
Right.
part of global.
So you would just put UTI visit and then not mention the pregnancy whatsoever.
Correct. If it's not related to the pregnancy, if it's not a prenatal visit, they came in because they have a UTI, I would just bill the UTI.
They had wild sex, Shayna, and they got a UTI.
You know, I hope all my pregnant patients are having wild sex, honestly.
I-
Have a little fun.
But you promote that.
No,
But-
I mean, the what we all know what usually happens, which is they're there for their prenatal visit and they're like, as you have
By
your
the
hand
way.
on the door, they're like, oh, by the way, I've had this discharge for the past week, or oh, by the way, I have a UTI. It's not the other way around usually.
And in that case, you can't bill for it because they were there for their prenatal visit. And well, it depends on the payer. Some things are really payer specific because it doesn't specifically state in the definition of global maternity care that you can't bill for a UTI. But under the maternity policy for most payers, a UTI is included in their maternity policy.
What if Arden, you had an EMR?
COVID.
We need somebody to mute their phone.
Contact with a positive person in the last few days.
Can we, I'll try to mute who I think it might be. Go ahead.
So let's say you have that same scenario. It's a pregnant person and they come in for the prenatal visit and they have a UTI. So could you open, if your chart allows you to, your EMR, open a different visit and chart the UTI completely as a problem visit not under their prenatal chart?
You
Then
can,
bill
and
it.
I'm not saying not to bill for it. You can try to bill for it, but
Deny it.
it more often than not will deny. So you just realistically have to know that it's probably going to deny. And if it doesn't deny, if it pays, well, that's an extra, depending on the state and the level of visit, $50 to $100. So that's a bonus.
Okay.
Here's another question, Arden, from Sarah. When billing incident 2, is there a modifier you add to your level of service, or is the incident 2 billed on the back end?
There's no modifier. It's billed as though the physician did the visit. It's the charts have to indicate that it was incident 2.
It's not a
it
problem
goes-
if they audit you.
Yes, exactly. Or, some payers like United Healthcare currently, for most global maternity claims, they're requiring chart notes. And it's not, some people state it's because they're doing a hard audit. They're not doing a hard audit. They've implemented a new program where they are reviewing charts for global maternity care. And then if they notice that an office is billing wrong more than 50% of the time, they send someone to that office to educate them on how to bill correctly according to their maternity guidelines.
So if nobody from the hospital system has told me I need to put that direct supervision wordage in there, I assume that we're not doing the incident 2 billing then?
I would never assume, and we're going to go into that here. We can do that next. How do you know how your services are being billed? I would never assume that you're not billing incident 2. How you know how your services are being billed is ask to see your billing records. The OIG, which is the Office of the Inspector General, in February 2012, they put into law that you have the right to view all billings submitted in your name. And your employer has to show you that billing if you request it.
And this is one of my favorite things to let people know about when you're trying to negotiate salary. If somebody says, well, we can't give that to you, or, you're not allowed to see that, that's simply not true. Now, are you going to be antagonistic and approach them that way? No, but there is a way to educate people about why you brought the question forward. And I think a lot of people don't know about this fact.
I agree.
Especially when you see the contracts that you're going to sign, and then somebody tells you, oh, by the way, we're not going to let you see that information. Here's another question, Arden. How do you handle clients that have both private insurance and Medicaid?
As far as incident 2?
I'm not sure. Brandy?
Yes, incident 2 billing with patients who have both. We have a very, very high population of patients who have private insurance with very high deductibles. And so they almost always start as private insurance payers. And then within a couple of months into their pregnancy, they have Medicaid as well. So I'm questioning just the incident 2 billing with the patients that have both insurances.
It depends on the Medicaid guidelines for your state. That's the first place to start. If the Medicaid guidelines for your state in the Medicaid provider manual state that the provider that renders the care has to be the billing provider, then you cannot bill incident 2. But you have to look at both the nurse midwife fee schedule and billing guide and the physician billing guide, because the physician billing guide might state that they are allowed to supervise for incident 2 billing. And every state writes their own Medicaid guidelines.
You're going to go with whichever one is the most strict with their rules. And most
Correct.
likely it'll be the Medicaid.
The other way to know how your claims are being billed is it very well could be stated in your employment contract. And the next slides, we have some examples of employment contracts that we have seen. This contract states that the employee shall accurately and correctly document all services and supplies, including services and supplies incident to, in the all charts. The documentation shall be included but not limited to designations of ICD, ENM, CPT, etc. The employee shall ensure that all coding or that coding shall be in compliance with applicable statutes, regulations, and federal, state, or private payer healthcare program requirements, in addition to all written policies and procedures of the employer. Here's where it then goes on to say the employee shall reimburse the employer for any costs and penalties incurred by the employer in connection with post-payment audits of the employee's coding. So if you're audited by Medicare, Medicaid, or third-party payers, and there's a take back, you have to pay the employer back.
Even when you stop working for them.
Even when you stop working for them. This contract states that the employee shall indemnify and hold the PC and its shareholders harmless from and against any losses, costs, claims, liabilities, or expenses that may be suffered by such persons arising out of the employee's conduct. And then it goes on to also include audits and overpayment demands by third-party payers.
Which means if the practice gets in trouble
They're
and
gonna come after you personally.
someone says that you were involved, yeah, they're going to go after you and hold the company and the employer harmless. They didn't do anything. If you're aligned with the issues at hand, this is, yeah, it's not a good one.
We did not
No.
recommend either one sign those contracts.
No,
There's provisions in there.
or the next one either. The next one is the best one, in my opinion. Improper coding and submission of billing by the professional will be the responsibility of the professional, both monetary and or criminal. It's the assumption by employer that these codes will be accurate and proper in accordance to standards CMS, Medicaid, third-party insurance company, CPT, and ICD designation, requirement, and classification. Failure to have adequate, accurate coding and billing will be considered by employer as a breach in contract and may result in the termination of the agreement, contractual relationship between the professional and the employer. How do you control that if you are not the one submitting the billing? How do you control that if you are just charting and there's a coder on staff responsible for your coding?
Or they bring you in, you're excited about working, and you're never trained in accurate coding.
Mhm.
And oh, by the way, you never get to see your accounts that have been billed for on a monthly basis. That's what a lot of our midwives are working under, blind beliefs.
And I will go back to what I said earlier. The person, whether it's the midwife, the MD, the nurse practitioner, whose name is on the claim, whose NPI number is on the claim, is the responsible party in the eyes of Medicare, Medicaid, and the third-party payer. That's why it's very important to know how claims are being billed when they're being billed in your name. So what do you do if you're engaged in a relationship as an employee that you think is problematic, or you discover billing practices you now realize are wrong? You can meet with the practice manager or the billing team. You can suggest to stop submitting claims and make formal notes of your meetings. If you feel you're not being heard or the problem fails to be corrected, you can seek legal counsel. You can ask for the billing services to determine what money was collected in error from patients and from federal healthcare programs, and then report and return the money. You can remove yourself from the suspicious relationship if no action is taken, or you can consider using the OIG and CMS's self-disclosure protocols. And they have a vehicle available for you to voluntarily disclose self-discovered evidence of potential fraud. CMS states you're supposed to stop billing immediately and report your employer, but CMS doesn't always live in the real world. So you need to do what you feel is best to be protective of yourself. And if you have information about fraud and abuse against a federal healthcare program, you can use the OIG fraud hotline to report that information to the appropriate authorities. One thing I will say is if you are employed by a practice that accepts Medicare, Medicaid, TRICARE, any federal program, that practice is required by law to have you undergo fraud, waste, and abuse training once a year, so that you are aware of what is considered fraud, waste, and abuse, and how to report it if you suspect it. And then all of the resources that we use to gather this information are included as well.
So how about we stop sharing the screen, Arden, if we can get everybody's pictures on here together a little bit better in the last 15 minutes here. Any thoughts, new information, increased anxiety? You feel good about what you heard? How are you feeling?
Increased anxiety. Yeah, a lot to think about. The thing I'm stuck on, because we have a new employee, I'm not sure how we're doing our billing. I know I've been getting more involved with it because I'm RVU based, and I am combing through my RVU reports meticulously now and finding a lot of mistakes. But anyways, this new employee, she's a nurse practitioner, so they have her doing all the new OBs because she can't catch babies and do some of the other stuff. But I know she doesn't have her Medicaid clearance yet because she can't send prescriptions. She has to send them under the physician's name and ask the nurse to do it. So I'm just kind of concerned about that.
It depends on your state as far as the Medicaid and what their guidelines are for the physician. If she doesn't have her Medicaid credentials, she can't bill incident to the physician. Mm-hmm. But are there other guidelines specified within the Medicare handbook that allows her to follow the physician, so to speak, and provide follow-up care or
I'm in Missouri, but I'll have to ask our office manager about that.
I can tell you, I have a pediatrician friend who they have an in-house billing, and she discovered that her biller was billing incident 2 incorrectly. And so she turned herself in and reported it, and she was very nervous and scared, and made copies of everything, sent them literally boxes of documents that showed what had happened and what had occurred. And they actually told her, okay, up to this date, we're going to ask this much money to come back to us because it was paid incorrectly. But before that, we don't even want to know about it anymore because you're creating too much work for us. So coming clean, it can be very helpful. And I had an issue with an employer that did some things with the IRS that was wrong, and I had the same thing with them. The sooner you find out that there's a problem and you report it and you go voluntarily and you don't just wait till you get caught, generally they're going to work with you. You know, if you're presenting as it was a mistake, I recognize I made a mistake, we want to fix this.
That's correct. And in the CMS self-disclosure protocols, they even state that if you disclose that you have discovered these things were happening, you weren't aware of it, and you self-report, that they will, I just pulled it up to double check, but they may waive all penalties.
Yeah, that's what they did with her. She just had to repay back the money that was overpaid, but all penalties were forgiven, and they even drew a line and said, we're not going to go back much further than that. But
Yep,
then
they treated it as a take back instead of as a penalty.
But I also know another physician who owned a group of urgent care centers who is now in prison. So, you know, that's the opposite of that, of knowingly billing fraudulently and trying to get away with it for as long as he could. And now all his businesses are closed and he's in prison.
There was a case when I was doing a search for this webinar of a physician and nurse practitioner late last year who were intentionally billing fraudulently for some time and were reported and got caught. They're both in jail. So I think the point of this is, Krista, first of all, this is a new employee. This hasn't been going on for that long. I mean, and it may be just something that could be clarified really easily on a phone call. Because if they're being stringent about the pharmacy side, maybe they just don't know.
That's what honestly, I think it would be a lack of knowledge, but to know, like, do we need to stop it before she continues? Because she's considered really like a Band-Aid position until we can recruit a physician. She's been with us for about 3 months and will be at least 1 year, but that's the main focus, will be getting all the new OBs in. And I mean, really the Medicaid should come through in the next month or two.
So then in 2018, I had Maxine.
Other thoughts? Yeah, Shayna.
So sorry, I'm talking a lot tonight,
No,
guys.
you're not. It's okay.
So in considering going with a third-party biller, in the contract that we will be signing with them, I don't have that contract yet, but there should be reasonable assurances that if something happened, that they would be responsible, and that they, I assume, have insurance and ways of reassuring us, I guess. Is that correct? Is that a smart way to go overall, I would hope?
So your contract with your third-party biller should, whether it's in the contract or they should provide you with errors and omission, E&O insurance, errors and omission, a copy of their policy. They need to have liability insurance. Most third-party billing services do not assume any liability for claims reported incorrectly. because it's ultimately the provider who rendered the care's responsibility to chart appropriately.
Right, but
Now,
if we're charting correctly and we're putting the correct things like diagnosis, and then they're just billing it incorrectly, we're trusting in them to bill it. So that would not be on us, right?
Well, yes and no. You are trusting in them to bill it. I agree. And they should have something in their contract that states that if they billed incorrectly and it results in a take back, that they will refund you any commissions paid on that incorrect billing. But they are not going, in all the third-party billing contracts I've ever seen, I don't think that any of them are going to state that if they bill incorrectly and it results in a take back or a penalty, that they will pay that for you. That becomes your responsibility.
And that's why we're seeing it, Shana, in contracts, that these are typically templates, physician contracts, substitute, not physician, but practitioner. And these hold harmless agreements and clauses about you're responsible for your own billing should it come back is for this very reason. And so that's been my perspective, that it's, unless they're blatantly billing wrong so they can get more money, right? There's always the bad biller, I guess, who tries to get more money for their billing service, Arden.
There are, and if a billing service says to you, we go by what the insurance company does, not by what they say, that's a huge red flag. What some billing services will say to you is, well, even though the insurance company says they don't cover home birth, for example, we will go ahead and submit the claim with an office visit code. And if it pays, then great. We'll submit all of your claims with an office visit code instead of a home birth code. That's fraudulent billing. That's a red flag. And there are billing services out there that will make that promise to you.
Ouch, that was harsh. I also think that, I can't make this stuff up, but I'm going to share. I have talked to midwives, certified nurse midwives in this case, who have worked for entities where they're the only CNM. I haven't talked to any CMs. And all the services for anybody who's provided any care is billed under the CNM's license number. So if they're in a 24/7 call rotation with non-CNMs, the global billing still goes under the CNM's license and NPI number.
I have talked to midwives in the
Can't do
same
that.
situation, and they've never even laid hands on the patient or eyes.
And that's just asking for an audit, because the insurance companies aren't stupid. They're going to know that one person can't be doing all these births.
Why would they do that? What is the benefit?
You get paid at a higher rate.
Or some states, there are some states where the insurance companies will only pay a CNM, and they're contracted. They will only contract with a CNM, or the state regulations state that the care has to be rendered by a CNM. So they're hiring one CNM to cover themselves in billing, or so they think, and then they're hiring additional CPMs, pay them less money, and the CPMs render all the care.
These are generally birth center practices.
Mhm.
It's definitely not incident to billing, which is why this kind of comes back into this theme of this sort of incident to has been around forever and people self-define it. And I think you heard somebody earlier say, there's some smart people at CMS that realized it was being abused. Therefore, the rules have become stricter and stricter. So the definition is less gray and very, very clear. And so we just want to make sure people know, because if you know, you have a choice to change. If you refuse to change, that becomes your own decision. But incident to is not this sort of laissez-faire issue anymore. And there could be OB practices who just don't know because they're busy practitioners. And if their office manager isn't keeping up with the 450-page manual that just came out or attended a webinar, then they don't know.
Yeah, I think the majority fall under that. No, they're not consciously committing fraud. They just don't know any better. And you used to be able to do it that way.
Right.
Correct. And I would 100% agree. Most practices just don't know any better. They're just doing it the way they've always done it. And it used to be okay. It just isn't okay anymore. And I would advise any of you who are practice owners, administrators, directors, to designate somebody in your practice to subscribe to the CMS updates. You just go to cms.gov and you can subscribe to their updates.
Arden, could you also give everybody a reference to where they can get the annual training for fraud and abuse?
Yes, you can actually, I can add a link at the bottom of the slide, but you can get that now from Department of Health and Human Services website, I do believe.
Yeah, if you just Google CMS fraud, waste and abuse training, it'll take you right to the site. But I did not know this. There's 2 different trainings. It's like A, B, C, and D, and you've got to do them all.
Yes, you have to do them both. You can pay somebody like fraudwasteandabusetraining.com to do it for you. But here, I just found it. I'll put the link.
We just made everybody go through it so that we're all compliant, and it'll tell you it'll take 30, 45 minutes. It takes a fourth of that. It can only take you that long if you're an incredibly slow reader. So it really doesn't take a long time. It's not like you're asking somebody to commit a 3 or 4 hour of their day. They could do both trainings in probably under an hour.
And you can do them as a group. It doesn't say you all have to like register your name because it does, Leslie, it does generate a certificate, doesn't it?
Yeah. I'll show you.
So you have to type your name in, but you can have everybody sitting in the room together if you want and do them as a group. I just put the link in the chat and it's about halfway down the page. There's combating Medicare Part C and D fraud, waste, and abuse. And then Medicare fraud and abuse, prevent, detect, and report. And you have to take both of those trainings to be compliant.
So once a year, you just have everybody go on the website, do it, print out their form and stick it in their file. And then that way, if you ever get audited, you can show that you've done your training.
And you're required to do it if you bill any government payer. So Medicare, Medicaid, TRICARE, Federal Blue Cross Blue Shield, and now Aetna's new federal plan that they have.
We need a spicier topic next time.
I think we need a fuzzier feel-good topic next time.
I agree.
For those of you who are on, I'll just give a pitch. Next Wednesday night, Baby Scripts is going to do a webinar through Grow Midwives, 2 nurse midwives, one from, I think it's a DC midwife. I can't think of her name right now. You may know who she is, Shayna. I think she works at MedStar. And then Suki from Bay State are going to talk about Baby Scripts. It's essentially virtual technology and its use in prenatal care primarily. So we'll be pushing some stuff out for them over the next few days, but I don't know much other than that for them to come on, but we're glad to host them.
Oh, sorry. Brandy asked if she could share something nice, please.
Yeah, I ended on a good note.
Incident tubing is just so complicated. So when I first started at the practice I'm at, I was a new midwife, and my physician has been practicing for a very long time. He just passed his 40 years. And so incident tube billing, of course, has been along for a long time. So after about a year working with him, I got my privileges. I started to do births. And because I was a new midwife, he came with me to all of them and helped me with training. And so our billing worked easily because he was always right there. And then as I grew, it's been many years now, I grew and he just liked coming to the births. And he had started changing the way that he did births when I wasn't there to the way that I do births, like with where the dads help catch the babies and things like that. And it always worked for our billing because he was literally present in the room. So he's over the years evolved into being my photographer. So he comes in and he has their phone and he gets up at the head of the bed and he cheers and he has just a great time, and he does all the photography for the room, and I do the birth, and the dad delivers the baby, and it's just super sweet. And then we built Incident too, and it has, I think, I'm glad to hear the seminar tonight, but I've always hoped that we were doing that correctly, but he's in my room, so it's fun.
Yeah.
That's like the perfect scenario. And I think it's really cool that he's now your photographer.
Yeah.
I
Very
say it
nice.
every time. I'm like, hey, everyone, we have to wait for the photographer. He's coming. Just a minute.
Okay, well, thank you, Brandy, and thank you all for attending. I'm going to turn off the recording.